Hello. So I'll try and talk you through all the information we received. This was part, as Nigel and Harriet have already explained, of the same survey we carried out over the 2-day period to try and get denominator data, very comprehensive data to allow us to interpret the reports of perioperative anaphylaxis we received to NAP6. And so I'm not going to go through this because Harriet's already explained. Just to highlight, this chart here shows you the number of returns by LCs, and the median was about 39. But with the scaling factor that Harriet has already explained, we worked out an estimated annual caseload of over 3.1 million procedures. In terms of intended consciousness level, as you would expect, general anesthesia takes up the majority of these at about 76%, with all sedation cases accounting for about 8% and 14% cases of awake procedures. In terms of numbers of drugs used per procedure, we were able to work this out based on the information we received, and we found out that more than 3 drugs were given to more than 90% of these patients, with a median of 8 and a maximum of 20. So this is a simple statistic, but gives you an idea of how difficult it can be, as I'm sure you are all aware, diagnosing anaphylaxis on the one hand, because there's a number of drugs which can themselves cause manifestations of anaphylaxis, especially when interacting. But more importantly, diagnosing what the culprit might be amongst all those drugs that were given almost simultaneously. So that can be quite challenging for us allergists. And this is one of the reasons that I don't think can be changed. So we asked this question whether the choice of drugs used was influenced by previous allergy history. And the vast majority of you said no, 90%, a little bit more, but still almost 9% said yes, and out of these, 2/3 were due to a past history of antibiotic allergy. Now, I would hope that most examples won't be as extreme as those, but these are available out there, and I can tell you, as I'm sure you will know, that most of these patients will not be allergic to all these drugs if properly investigated, but there we are. In terms of induction agent use, propofol was by far the most common drug used, and this happened in almost 90% of all cases and 90% of all general anesthetics. And this was the case across all age groups, as you can see there, which was similar to what we saw in NAP5. The one difference mostly was that in cesarean sections we saw an increase in use of propofol, whereas thiopental use has decreased. It still is the major induction agent used in this group of patients. But we feel that this may be as a result of some of the findings from NAP5, which looked at accidental awareness during general anesthesia and found that C-sections were one of the procedures that had risk for this to happen, and thiopental one of the most likely drugs to cause it. Amongst surgeries or general anesthetics where maintenance agents were used, an inhalational agent was used in 95% of cases, and sevoflurane was the main one. Again, this was the case across all age groups, as you can see there, including in C-sections, although in that group we also saw a significant number of patients receiving nitrous oxide. We have seen a decrease in use of nitric oxides compared to NAP5 by about 30%, and we speculated this could have something to do with the published ENIGMA study, although the ENIGMA 2 study published subsequently has dispelled some safety concerns, particularly in elderly, or including in elderly patients. Use of neuromuscular blocking agents. They were used in almost 50% of all general anesthetics, and the most common, or the predominant drugs were atracurium and rocuronium, which accounted for 50 and 40% of all NMBA use, as you can see here. This was the case again across all age groups, although in C-section succinylcholine was used almost slightly more preponderant. We did not have the same level of detail for NAP5 to compare, but because this only collected use of succinylcholine or non-depolarizing NMBAs, and we could see that the proportions were stable, although there was a slight decrease in the use of succinylcholine in NAP6. In terms of use of reversal drugs, these were used in about a third of all GAs and about 2/3 of all GAs where an NMBA had been used. And neostigmine was the most commonly used drug. But going back to what Harriet had presented, our data show that there is consistent underuse of reversal drugs and in the use of neuromuscular monitoring, which perhaps shows that there hasn't been such an improvement in practice relating to NAP5 recommendations in this area. And it is also one of the minimal standards for monitoring from the AAGBI. With regards to analgesic drugs, they were used in 88% of all cases in virtually all general anesthetics. So an annual case load of 2.7 or 2.8 million, with opioids being the most common group selected, 82%, 2.5 million administrations. Paracetamol, you can see in the chart on the side. So with the opioids, the fentanyl and morphine were the most common drugs used. Paracetamol was used in half of the cases of the procedures, and NSAIDs in about a third, with diclofenac being the preferred choice. With regards to antibiotics, they were used in more than half of all cases, in fact almost 2/3, with again an annual case load of 1.8 million, just under. Gentamicin, comoxiclav and cefuroxime were the main antibiotics used, as you can see in the chart. And for instance, comoxiclav accounted for more than 500,000 administrations per year. Between these three, they accounted for about a third of administrations of all cases receiving antibiotic. And another thing to highlight that will be picked up later when we talk more about antibiotics, unsurprisingly, was when we looked at choice of antibiotics at past allergy history, we did not find any effect on use of comoxiclav, as you would expect. But you can see here that choice of, or history of past allergy to an antibiotic influenced the choice of teicoplanin and vancomycin use in more than a quarter of cases when these drugs were used. Now, we didn't collect data on which antibiotic the history was of, although we suspect this is very likely penicillin because this label is carried by about 10% of the general population and 20% of inpatients. And so it is very likely this was the reason. And this has already been raised and will be raised later on. Now, this is, I think, an important piece of information because it gives further strength to the calls, I think, from the community, particular allergy community, to delabel these patients, because we know that the vast majority of these patients actually do not have an allergy. These two charts give you information about use of antibiotics by specialty, and you can see there's a wide variation in terms of overall use. General surgery and orthopedics and trauma are the specialties that used more antibiotics. But then when we look at the proportion of cases within each specialty receiving antibiotic, cardiac surgery tend to give it to virtually every patient, and they're closely followed by neurosurgery, thoracic surgery and neurology as well. And then the chart on the right shows you the distribution of individual choice between each specialty, which shows a wide variation of choices. And some of this may be determined by specific guidelines, but it would require further investigation, as we suspect. Some of it, we don't quite know what the rationale is. And again, that has been raised already. Local anesthetics. They were used in about 3/4 of all cases. And you can see the distribution here according to the level of consciousness. This shows that it is likely, based on the widespread use and the distribution of drugs selected, that the most appropriate patients are receiving neuraxial and peripheral nerve block and local anesthetic infiltration. And we know the former two are associated with improved patient-reported outcomes. So this is interesting and good evidence that this is being used more. In terms of anti-emetics, there was a question earlier about use of dexamethasone. So they were used overall in almost 3/4 of cases, with ondansetron and dexamethasone understandably at the top. Within general surgery, the dexamethasone was used in 60% of cases, as Nigel has already mentioned, and ondansetron and dexa combined were used in about 53% of all cases. With regards to drugs affecting coagulation, they were used in about 8% of all cases, with tranexamic acid being used in about 6%. Intravenous colloids and blood products. So overall use was about 4%, with blood products used in about 3% of cases, and synthetic colloids in less than 2%. Gelatin accounted for about 90% of all these, but we wanted to highlight the use of starches, which was about 1 in 600 cases, but still significant, particularly considering that the EMA has issued a ban on its sale this year. We couldn't find any pattern in terms of the use of starches, apart from the fact that it clustered from about 17 centres, but there was no particular pattern in terms of specialty that we could identify. Latex, reported in about 70% of cases, although only 1/5 reported latex-free exposure. Unsurprisingly, gloves were the main source of exposure. Miscellaneous drugs used very little, but I'd like to highlight the patent blue dye, 2% of cases, particularly considering the number of cases of anaphylaxis we've subsequently seen in the report, which made it the 4th main cause identified. Chlorhexidine, another big one, was reported to be, of patients to be exposed in almost 3/4 of cases, and unsurprisingly by skin preparation by the anaesthetist or the surgeon. You can see here the distribution of use across different specialties, and it's quite variable, although most of them will use it significantly, but obviously cardiac surgery stands out as the one that uses in virtually every patient, whereas on the other hand, ophthalmology doesn't seem to use it as much, and you might be able to see an explanation for this in the next slide. The main thing I wanted to highlight is this proportion reported, and in fact the fact that about 1/5 of cases were reported as no exposure. And this, knowing that chlorhexidine is an ubiquitous antiseptic in the healthcare setting, it is recommended to be used for prevention of surgical site infections by national guidelines, including NICE, and many local hospital guidelines will also recommend its use, even before venous cannulation. So it perhaps reflects underreporting due to under-recognition of the use of this antiseptic, not only in the wipes and the antiseptic solutions, but also, as I've highlighted here, in urethral lubricants and coated, not all, but coated central venous catheters. Povidone iodine, not unsurprisingly to be reported, patients to be reported in about 2/5 of cases, and mostly via skin prep by the surgeon. And exposure by specialty variable, but this is where the ophthalmology apparently seemed to use a lot more povidone iodine than chlorhexidine. So in summary, this allergen survey was, or is the most recent and comprehensive national survey of anaesthetic practice, and provides detailed and unique, we believe, data on drug use and allergen exposure in perioperative care, particularly in a number of different drugs that we didn't have information on before, including analgesics, antibiotics, local anaesthetics, other miscellaneous substances, and antiseptics. It was very important as used as a denominator for the NAP6 reports to work out incidences, and we also believe it provides new insights into many aspects of perioperative practice. Thank you.
Well, thank you, Susanna, for that very elegant presentation. It'd be quite interesting to know, following on from what you were saying about chlorhexidine use, we generally felt, the panel felt, that chlorhexidine is used more commonly for skin prep, for example, peripheral cannulation, than was reported. Can I ask for a show of hands, anaesthetists who don't use, for whatever reason, chlorhexidine for skin prep for peripheral cannulation. Don't use it. Their hospital doesn't use it. Yep, okay, I think our perceptions have been proven, thank you. Yeah, it is ubiquitous, yeah. Now, I'd like to now introduce Cale Kong, anaesthetist from Birmingham, who has a long time interest in perioperative anaphylaxis, and he's going to present the first of the data that's coming out now for presentation from the case reporting phase, and he's going to present the clinical features of these anaphylactic reactions. Cale, thanks.